Good afternoon, everyone. I would like to welcome to EASL Studio, your weekly hepatology broadcast news. Today's episode is dealing with the impact of policy measure in preventing liver diseases. The Hepahealth II study, which was published recently in Journal Hepatology. And as you can see, we will discuss with three outstanding speakers. Professor Maria Buti, she is the EASL Public Health Counselor. She will end her term at the EASL Congress in Milan in June. And she will be replaced by Professor Shira Zelber-Sagi. So she will become the next EASL Public Health Counselor. And then we have Peter Jepsen, well-known, recognized expert internationally recognized expert in liver disease, in particular alcohol-related liver disease and hepatocellular carcinoma. So I think to understand what is the reason and the meaning and the insights of the Hepahealth II study, we'll give the podium to Professor Buti. Maria, please.
Thank you, Patrizia, for the invitation. The rationale for Hepahealth II study is our concerns on implementing policy measures because we are seeing an increase in liver diseases. According to EASL Lancet Commission on Liver Disease is now the second leading cause of years of working life lost in Europe, only after ischemic heart disease. And this is due to an increasing unhealthy use of alcohol and the epidemic of obesity. It has been estimated, just to give some figures, that almost 30 million people in the European Union live with chronic liver disease. And the proportion is higher in Eastern European countries. Liver-related death accounted for 3% of all deaths in Europe in 2019, which is an increase, a 25% increase in relation between 1919 and 2019. And this increase is due to chronic liver disease and also to liver cancer. And when we look at the risk factors for chronic liver disease and liver cancer, alcohol and obesity, and both the combination of alcohol and obesity are the main risk factors for liver disease. So both factors can be prevented. So why not to introduce policy measures to decrease the risk of liver disease? And this is the rationale of Hepahealth, to evaluate, to assess the impact of policy measures to reduce liver disease in Europe.
And I think, thank you, Maria. I think what is important in this case to find really the model to identify these risk factors. So we really need, in some way, a simulation modeling. And so I will invite Peter, Professor Jepsen, to tell us how was that model built up for the Hepahealth II study.
Yes, thank you very much, Patrizia. Yes, it's quite a difficult task I've been given here to try to explain this microsimulation modeling, but I will do my very best. But first, maybe I should explain why we chose the three countries that we did choose: France and the Netherlands and Romania. So that's mainly based on the results of the Hepahealth I study, which divided the European countries in groups with respect to the time trends in the incidence of chronic liver disease. So and they mirror the incidence of alcohol-related liver disease. So we have chosen the Netherlands as a representative of a country with a stable low incidence of alcoholic liver disease. And we've chosen France with as a representative of a country with a decreasing trend in the incidence of alcohol-related liver disease, whereas Romania represents countries with an increasing incidence in alcohol-related liver disease. And of course, this has to be combined with availability of data. So that is why we chose France specifically, because we had data available from France and the Netherlands and Romania for the same reason. So it's a combination of having data available and those three countries representing different time trends. All right, and now then to the microsimulation, which has the people, the health flumen people who did the actual simulation, they describe it as a modular simulation process. So it consists of different modules, and let me just walk you through them. First of all, there is the population module, which for each of those countries describes the population composition of France, the Netherlands, and Romania. So what was the population demographics like in 2022, and how did it develop for each year through 2030? How many were born? How many died? What was the immigration pattern? And what was the demographics to begin with? Based on that information, you can model the demographics for each year through 2030. So that was one module. Another module is the prevalence of the risk factors that we're interested in here, alcohol consumption and BMI. So they needed to collect baseline information, that is the data for 2022 by country, by gender, and by age. Then in another module, the development of BMI and alcohol, well, alcohol was held stable. So the development of BMI through 2030 for each gender and for each age category and for each country was modeled in a separate model and then fed into this particular module for the simulation process. Okay, so that was the population, and that was the risk factor modules. And now the next module describes what is the risk of developing chronic liver disease or liver cancer depending on your specific characteristics. That data was also fed into the model. And then with those modules in place, you are then all set to compute the baseline, the what we call the inaction scenario, where we can module the incidence of chronic liver disease and of liver cancer if nothing happens, meaning that current policies stay in place. Having done that, the group modeled 7 different policy scenarios. So there were minimum unit pricing on alcohol introduced in one, or rather in 2 different scenarios, one with a minimum unit price of €1 and one with a minimum unit price of 70 cents. Then there was an alcohol volume tax. And then there were 2 different policies targeting obesity. There was the tax on sugar-sweetened beverages, and there was what's it called? It's called a food marketing restriction. And then there were 2 combined policy scenarios where one of them combined the 70-cent minimum unit pricing with the sugar-sweetened beverages tax. And finally, there was a combination of the 70-cent minimum unit price and the alcohol volume tax and the sugar-sweetened beverages tax. So all in all, there were 7 action scenarios that each of them was compared with the inaction scenario. All right, so the final thing that went into the simulation was, how does, say, a 70-cent minimum unit price affect your risk of developing chronic liver disease given your current age and gender and country? So you can tell that fundamentally it's quite simple, but there is a lot of data that goes into this model and each of its modules, and it quite easily gets very complicated. And of course, it was a huge task to collect all this data that was fed into the model. But the output is quite easy to understand, essentially, because what you get is how many people by 2030 will have developed chronic liver disease if we do this versus if we don't do anything. So I think really this is the beauty of it. It's extremely complicated under the hood, but the output is very easily translated into something tangible. It's something that should resonate with our politicians. And before I stop talking, I just want to say that the publication presents two outputs. That's the incidence of chronic liver disease and the incidence of liver cancer. And then there is something on costs. But I want you to know that on the webpage, on the EASL webpage, there is a fuller report with more outputs. All right, so I think that will be my cue to give the word back to you, Patrizia.
Yeah, I think you try to convince us that this modeling, this simulation modeling is is complex but feasible. But I think we are clinicians, so hepatologists, and I think our audience would like to see how did you get it from this modeling the results then. So Maria, you want to add something to this?
Yes, we try to convince policymakers, particularly we try to convince that these public health policies have a significant impact on reducing, as Peter has said, the burden of liver disease. You are right. First, we need to convince clinicians, but our endpoint is to convince policymakers.
So I think now Shira's duty. She has the task to show to us the results, and they are the data that were published in the paper. And of course, we understand that the model is quite complex, but then the results will really help us in understanding the application of this simulation model. So Shira, please.
Yes, thank you. So the good news after all the long explanation on the methods, and it was indeed a very long and complicated process of microsimulation. But the good news is that all the policy scenarios that Peter mentioned, all the alcohol policies, the food policies, the advertising restriction, and the sugar sweetened beverages tax, and the combinations of all these policies in different ways, all shown that if we would apply these policies, we can reduce liver disease burden in the 3 countries we studied, and probably in Europe if it would be applied more broadly. So what I'm going to show you now to simplify the results presentation is the 2 best policy scenarios with the best reductions in liver disease burden. So the first one is the reduction in the cumulative incidence of cases from 2022 to 2030 if a country, each of the 3 countries, implemented a €1 minimum unit price policy. So this was the winning scenario, by far the best scenario, and it emphasizes the importance of alcohol-related liver disease burden. So if we apply this policy, we get about 5% reduction in the cases of liver cancer just by putting the €1 MUP policy. If we look broadly, not just on liver cancer, but chronic liver disease, you can see interestingly that in the 3 countries, there is a similar reduction, a 7% cumulative reduction in the cases of chronic liver disease with this policy. Now we go to the second best scenario, which is a combination scenario. So here we try to see what would happen with a policy that applies 70-cent minimum unit price combined with sugar sweetened beverages tax. Why not €1? We try to be realistic. We try to say, okay, so what would be a realistic combination of policy measures that can be applied more comfortably or more feasibly in different countries. And here, the numbers are not as good as €1 MUP, but still very impressive. So for liver cancer, there would be about 3% reduction in the cumulative cases between 2022 to 2030. And for chronic liver disease, it's about 3.5. Again, there's a lot of similarity between the three countries. So if we need to choose, and I prefer not to choose, but obviously we need to go, if possible, for the €1 MUP. But again, even different combinations, whatever is more realistic in different countries is also very beneficial. And we are talking about thousands of cases of liver cancer and chronic liver disease that can be prevented. Now, it's not only life-saving or disease-saving, it's also cost-saving. These interventions will also save a lot of money. So we didn't have data for the cost saving for Romania, but we do have for France and the Netherlands. So for France, we could calculate how much money will be saved with the different scenarios. For liver cancer, only direct healthcare costs between 2022 and 2030. And I will just present the numbers for the best scenario, the €1 MUP policy implementation. So it's 612 million euro that will be saved in France for direct healthcare cost on liver cancer. This is pretty amazing. And if we move to the Netherlands and we look at the cost combined from direct healthcare costs related to liver cancer and chronic liver disease, so it's 17 million euro. This is a lot of money, and it can reduce a lot of burden for the health systems in these countries.
Thank you, Shira. Now, looking at the results, we can see really the efficacy of this application, in particular with the taxation implementation for the sugar, sweetened beverage, and for the minimum unit price. So I think now we can discuss. I think we can skip the slide and coming back to the screen, and just in some way we should tell to our colleagues what is your feeling about what we can do really about the risk factors. This paper is concentrated on the alcohol consumption and is concentrating on the role of obesity. Probably we need also to think about other risk factors, since they are not the only one for cancer from liver disease. So I think I will ask all of you, we'll start with Peter, related to the role of alcohol consumption in acute and chronic liver disease, actually, and also liver cancer. Peter.
Yes, so thank you very much, Patrizia. So I think this simulation clearly shows that a minimum unit price of alcohol is really a necessary policy to reduce the prevalence and the incidence of chronic liver disease in Europe, and also on liver cancer. So I think this is, I mean, we can discuss whether it should be €1 or 70 cents, but any policy that wants to be effective needs to include a minimum unit price. And I'm not just talking about this line of research that documents the effect. We've also, thanks to the good people of Scotland, seen what I would call a natural experiment documenting the effect of introducing a minimum unit price of alcohol on the incidence and the costs associated with alcohol-related liver disease. Because in Scotland, they introduced in real life, not a simulation, a minimum unit price on alcohol, whereas they did not in the UK. So by comparing these two otherwise similar countries, the researchers were able to demonstrate that a minimum unit price on alcohol does reduce harms from alcohol, including alcohol-related liver disease. So there are multiple lines of evidence demonstrating the effect of a minimum unit price. Also, I was very happy to see in the March issue of the Journal of Hepatology a study describing an alcohol preparedness index, which describes the very strong association between a country's policies with respect to reducing alcohol consumption and that country's prevalence and incidence of liver disease and also cardiovascular disease, again demonstrating that policies to combat alcohol consumption are successful in reducing deaths from alcohol-related liver disease. It's very important. So, I mean, we should go and tell our politicians that this is what you must do. And indeed, EASL does do that. This is something that we do, for instance, through the EASL Lancet commissions, where and in our Policy and Public Health and Advocacy Committee, this is something that we work for by working with politicians, with patient groups, and with other advocacy groups.
Yeah.
So I think we are really trying to do something here.
Yes, yeah, that is a very good point. And also the link, as you mentioned, with the EASL Lancet Commission. Now the second commission is working, and we are working on the action. And that's what you said is exactly what we are willing to do. And I think today more often we see patients that do not have only one risk factors. And this is why you remember that in Journal Hepathology in June last year was launched the new nomenclature for MASL, for the metabolic associated liver disease, liver steatosis. But today it's really rather difficult that to have the common standard, let's say liver disease patient with only one risk factor. And this is why I think, and I think Shira, you are the expert, we have really to have a different approach to the general population. We have to start much earlier about the nutrition and about how to drink, how to eat, and of course you have to tackle the obesity that's increasing. And Europe is, we don't want Europe to get as high as the Americans' rate of obesity. So what are your suggestions, Shira, in this kind of risk factors?
So I think Peter discussed alcohol, and I think, as you said, Patrizia, many times obesity, unhealthy lifestyle, and alcohol are combined together, yeah, and synergistically increased liver disease burden and severity. And you know, we ask the patients, do your diet, eat a Mediterranean kind of diet, fruits, vegetables, and avoid sugar. But then they leave the clinic and they face a toxic